Thank you very much for the kind introduction. I also like to thank Professor Berger for inviting me. It's always great to come to Berlin. I recall my very first stay in Berlin when I was 12 years old and had summer vacations here with my grand aunt. That was before the wall went up, and I've been there also after the wall came down. What I like to do with my talk is to bring a little wall down on the way we think about right ventricular failure. I have to make a disclaimer, I'm not a cardiologist at all. I'm a pulmonologist with a long interest in the lung circulation. So what I'd like to do today is to talk to you about principles of adaptation, requirements for successful adaptation of the RV to chronic stress, and then the treatment of established RV failure. And I'll have an emphasis on carvedilol, and I'll say it right there because I will say it a couple of times during my talk, to set that drug aside from the other conventional beta receptor blockers. I want to make a case for this particular drug, and hopefully you will accept some of the rationale behind that. So, as you can see, adaptation is not the strongest of the species that survives, and not the most intelligent, but it is the one that is most adaptive to survive. So Darwin had that understood very clearly already at that time. And I'll start out with a very fascinating example of adaptive response. This is the story of the peppered moth that used to be predominantly peppered, as you can see here. And at the time of the Industrial Revolution in England, with coal mining and more pollution being developed, and trees are being covered with coal dust and with soot, what happened is that the white moth had been eaten by the birds, and as a consequence, the black variety became dominant. And we know now about the genetics of that, which is that you have one particular single gene called cortex that is in control of a transposome and developed the switch mechanism towards the predominance of the black species. So when we are talking about heart failure, in generic terms, we are talking about stress, and it comes as a response to stress, which is an adaptive homeostasis, or heterostasis, or allostasis. And the people that are working with these concepts of adaptation talk about a allostatic load that increases when there is an energy demand in excess of energy supply. And this is one way that you can define heart failure as well. It's a situation where the energy supply is wanting and the demand is excessive. And there are allostatic load sensors which gauge and predict the response of a successful adaptation. And in the case of heart failure, these are likely, although we don't know that exactly, wall strain and perhaps altered blood flow patterns. And these may lead to activation of the neuroendocrine system and also to immune and inflammatory responses. And this here is to tell you one concept that talks about adaptation to stress, which is that we are certainly at least dealing with two different hits. You have the mechanical wall stress strain that will activate cortisol production, epinephrine production, which then will increase the production of interleukin-1. All of these are data that are in abundance, which then again feeds to activate corticosterone and will drive an inflammatory and immune response. So I introduced at that moment already the concept of mechanical stress leading sooner or later through both neuroendocrine activation and activation of inflammatory mechanisms. So why should we be concerned or interested in right function, right heart failure? Why does it matter? Well, in the adult world, maybe perhaps also in the pediatric world, patients with severe pulmonary hypertension die from right heart failure. And so when I've been on teaching rounds with my students and I had patients introduced to me and I hear about the degree of pulmonary artery pressure elevation, I would just for didactical reasons say, I'm not really interested in how high the pressure is. Tell me about the cardiac output. And all of that leads to the practical message that when you deal with pulmonary hypertension, you're dealing with the cardiac reserve and the cardiac stress. And the postulate that we have been working with over the last 2 decades or so is that right ventricular failure can be prevented, and once it is established, it can also be reversed, which is in contrast to the teaching at the 80s and 90s. And I just quote the late Celia Oakley, who said, when faced with an irremovable increase in afterload, right ventricular failure is untreatable and easily made worse. She is right, it can be made easily worse with the right kind of treatment, but I take issue with the fact that it is, in principle, untreatable. So the right ventricle under pressure can or cannot adapt, and the data in summary are rather clear that survival and exercise tolerance in severe pulmonary arterial hypertension are tightly related to successful adaptation of the RV, and the survival is inversely related to inflammatory cytokine blood levels. So we measure interleukin 1, interleukin 6, and if they're very high, that correlates with a very bad prognosis. What does that mean? We can talk a little bit as we go on. The other thing I would like to introduce that we have reasons to believe that there are a priori right heart failure prone and right heart failure resistant patients, which probably means that there are genetic determinants that we have to understand. I got introduced to that when I was a research fellow in Denver many years ago, and the significance of that particular slide is right here, where we looked at the long-term survival of patients, those were reported in the literature, with idiopathic pulmonary arterial hypertension. And you can see here for very high preload right ventricular pressure, pulmonary artery pressure, mean pressure, we had survival rates up to 7 to 10 years. And that was before we had any treatment. So that already says that there is a subgroup of patients who can live and survive for a long time with very high pressures. How are they doing that? Why are they doing that? I have been on a mission over the last 10 years or so to convince my colleagues that we need to collect patients with functional New York Heart Classification 1 patients and study them. And it has not happened so far. Another example is the longer survival of adult patients with Eisenmenger syndrome. And this is a rather simple anatomical studies where we just measured the thickness of the free wall of the right ventricle. And no matter where you look, at the base, at the mid, or at the apex level, for all of these situations, the Eisenmenger RV is much more robust, is much more muscular than it is in the patients with idiopathic pulmonary hypertension. And again, you have to say, for the same degree of pulmonary hypertension, for the same mean pulmonary artery pressure. Well, that's okay. That is sort of the observational part of it. But what is more interesting is when you look at the degree of fibrosis in the right ventricle, idiopathic vis-a-vis Eisenmenger, there is much less fibrosis. I don't know why that is, but if there is indeed a relationship of the degree of diffuse fibrosis in the myocardium to function and survival, then that may be one of the factors. The other thing that is finally becoming clear in the adult patient population is that the right ventricular hypertrophy in patients with idiopathic disease is a factor of long-term survival. This particular patient had been published by Stuart Ritz's group in Chicago, a woman that had been treated with suprasystemic pressures with infused prostacyclin for 19 years and never had one day of heart failure. She then developed colon cancer, and as she was getting worse and it was dying, she said, "I want an autopsy. I want you to look at my heart and my lungs." And the fact is that that patient had most of the plexiform lesions, a horrible lung circulation, and yet she survived because of this kind of a ventricle. Banding had been introduced before. These are experimental studies in rats where we looked at several months after the combination of PAB and chronic hypoxia. And you can see here that the right ventricle generates a pressure of 120 millimeter systolic. That is more than 4.5 to 5 times normal, and there was no sign of heart failure. So it cannot just be the afterload that is torturing the right ventricle. So one conclusion at this stage is that for the adaptation, the successful adaptation of the RV, hypertrophy is necessary. This is against the dictum, against the rules of adult cardiology that usually says any kind of hypertrophy is bad. So this sets this apart. So the hypothesis that we have to work with is that there are genetic and epigenetic determinants that encode a successful cellular and molecular RV adaptation. And an example is that patients with the BMPR2, bone morphogenetic receptor protein, protein receptor 2 mutations that are the best studies in the adult population, have a worse right ventricular function. Why that is, we don't understand, but this is just empirical at this moment. And therefore, we have to start to think about genotype and phenotype. And when I say that, I'm talking now about the right ventricle under chronic pressure. And as I already said, we can probably introduce the concept of failure-prone, failure-resistant phenotype, and also then a third phenotype, which is the one that is responding to therapy. So again, you will have patients, and the pressure is the same, and you have documented RV failure. Now you start treatment, and some do respond, and others do not. And that was first of interest to us more than a decade ago. Here we looked at a angiotensin-converting enzyme genotype, and you can see here that the mean pressure is identical for both groups. But when you break it down in those two genotypes, DD and non-DD, you see that those are the patients with a maintained cardiac output. They already have a low cardiac output, and the right atrial pressure is corresponding. So two groups at the time of diagnosis, already low cardiac output, otherwise with preserved cardiac output. The other thing that relates to the treatment response shown here from a recent study where they compared females with males and looked at the right ventricular ejection fraction improvement after therapy, and we can clearly see that the separation, that males have more problems responding to treatment with an appropriate increase in the RVEF than women. And this is an important study by the group in Amsterdam looking at the treatment effect and breaking down the patients that did or did not have an improvement in RVEF after treatment, regardless of the behavior of the PVR. So the PVR did not predict outcome. A decrease in PVR alone under treatment was not predicting outcome. An increase or a maintenance of the right ventricular ejection fraction was. If you think that through, that changes the ballgame from vasodilator therapy, from trying to reduce the pulmonary artery pressure and then looking at the PVR as Ohm's law to break it down like that, and gives a priority to looking at the right ventricular ejection fraction. And that may be of interest to you. This is a Lewandowski study looking at the RVEF of adult patients that were born prematurely. And you can see that some of these patients, without any other knowledge, have already quite a reduction in the right ventricular ejection fraction just because they have in their history the fact that they were born prematurely. And we need to go further and try to figure out why that is, what that means. So there are probably different kind of RV and maybe also LV phenotypes. And what the different component of that phenotype is shown here in that picture of a landscape sculpture in Nevada, where you see different stones with different colors and different elements, one symbolizing the genetic background, perhaps the fact whether you're born prematurely, and whether you have a gene program that goes in hyperdrive when the pressure goes up in the right ventricle, and whether you activate your neuroendocrine system. So let's move from pressure and volume to cells and molecules, and talk about these particular phenomena that we think are important acting out in heart failure. I think apoptosis of myocardiocytes and probably also endothelial cells, capillary loss, I will talk about this quite a bit, energy problems and fibrosis are hallmarks of failure. We start with a cardiomyocyte stress. We get hypertrophy at some point in time that then leads to deterioration in this direction. We have at some point in time activation of neurohormones. We get cell death. We get ischemia. We have inflammation. We have changes in the extracellular matrix. And all of that leads to a contractile dysfunction and to changes on the mitochondrial level, on the subcellular level. Because Professor Stiller talked about neuroendocrine activation, I'll show you here measurements of serum aldosterone levels. These are pulmonary hypertension patients that are not in failure. They have it already elevated, but when in failure, it is quite high. And there are multiple reasons to treat that. Let me introduce you the concept of the sick lung circulation affecting the heart, which means that the altered vessels, and particularly altered endothelial cell biology, this becoming an adhesive surface, proliferative cells, inflammatory mediator production site, all of these kind of factors will be filtered out in the next circulations, which are the coronaries, and will affect likewise both the right and the left ventricle. And that's not the end of it. There's also the idea of a cardiac secretome, factors that are now being produced by the myocardium. Among those here, ANP, BNP that you all know, growth differentiation factor 15, also interleukin-1. They act on the kidney, also on the adrenals, and we have feedback loops and vicious cycles there. One example is here, where Steve Kaywood in Philadelphia looked at von Willebrand factor, and these are low von Willebrand factor patients. These are high von Willebrand factor. You can see how the survival breaks down. Von Willebrand factor in this case is likely to be produced by the sick lung circulation. Another example, measuring particular growth factors. And here under RA, this is the radial artery, so that is in the systemic circulation, and that PA is before the lung, pulmonary artery. And you can see in each instance of these, the number of the growth factor, vascular endothelial growth factor, is higher, almost double, coming out of the lung. In other words, this is evidence for a AV difference for production site in the lung circulation. This is true here and also for TGF-beta. Well, what does the failing right ventricle look like? I took a picture from a local production from Professor Kühne, who is able to do a pressure volume curve with MRI. You can see here a balloon of a catheter in the cavity of the right ventricle. Normal right ventricle is thin-walled, here it is thick-walled, and you can see how the left ventricle size is influenced by the dysfunctional right ventricle. There is also from one of his papers increase in fiber stress when compared with the control group, both at systole and diastole. And he is able to look at intracavitary flow patterns. And this is the normal heart. You can see here that there is flow, that there are turbulences, and that there's really a lot of flow here in the outflow tract. And I cannot wait until he shows me data of patients with severe pulmonary hypertension. So let's go down to the tissue level. In the right ventricle, normal size of myocardiocytes and a good capillarization that is changed when you have failure to hypertrophy, and there is capillary rarefaction. And I will talk about that a little bit now. Which is the blood flow. As you all know, that the blood flow to the right ventricle can increase much more through the right coronary circulation on the left side, and the normal right ventricle receives already 37% of blood flow from the left coronary artery. Of interest, if you compare the vascularization in the normal heart with that in the patient with Eisenmenger heart, you can see that there is a very, very strong increase in the capillarization and the vascularization in the right ventricle in patients with Eisenmenger syndrome. And these data are old. They come from Cleveland from 1952 already. And Jens Voelkel-Clausen, when at Hopkins, looked at the right and left ventricular myocardial perfusion reserve, and you can see that here going down to the pulmonary hypertension groups, and astonishingly, the reduction is rather similar for the left ventricle and for the right ventricle on the term of pulmonary arterial hypertension. Experimentally, we can induce right heart failure in a rat model, and we look at the capillary rarefaction here in the RV, and you can see that there is a tremendous loss of the capillaries. My point is that it is time for cardiologists to not think about the coronary arteries, but think about the capillaries. Not only is there a rarefaction of these capillaries, there is also a dysfunction of the residual vessels. I'm showing here immunohistochemistry for the prostacyclin synthase in the normal, very small vessel, and you see here the lighting up of the cells of the endothelium, of course, that express the synthase, and here, in contrast, in the failing right ventricle, you have lost that, and not only have you lost the prostacyclin synthase, you have also lost the prostacyclin receptor. Lastly, if you do immunohistochemistry for vascular endothelial growth factor C, which function we don't understand in the myocardium at all, you see here a very intense staining around the vasculature and absence in the failing heart. And there's also a tremendous loss of vascular endothelial growth factor B. And B is very important, as we now understand, for the fatty acid transport across the capillary endothelial cells. In other words, if you don't have that factor expressed, nutrition is not happening, and fatty acids, which are very important for the energy metabolism of the myocardium, are not being transported. And as a consequence of that, if you do an imaging study of the right ventricle of patients with pulmonary embolic disease-associated severe pulmonary hypertension, you can see an accumulation of a pentadecanoic acid, that's a test substance fatty acid, after thromboendarterectomy in the same patient, that signaled that accumulation disappears. So these fatty acid nutritional energy problems do matter. There is stress to the kind of oxidation stress, oxidative stress. A marker of that is ceramide that clearly accumulates in the failing right ventricle here. And we have a problem of the mitochondrial level by looking at the expression of PGC1 alpha and other nuclear receptor, estrogen-related nuclear receptor, PPAR alpha. And you can do gene expression studies that will indicate that in the failing right ventricle, in comparison to the hypertrophied not failing right ventricle, you affect a whole big number of genes that are related to that transcription factor. You can also show that in the failing heart there is no more growth. Insulin growth factor 1 basically stops to be expressed in the failing right ventricle. This is banding for comparison, so banding still relatively normal. And that gets me to my last point of my talk. What can we do about it? Can we perhaps treat the right ventricular failure? This is a rat experimental study that I had to be convinced that it needs to be done, but the insistence of my postdoc and very successful young researcher in Amsterdam, Harm Bogart, steered us to look at carvedilol and treating animals with established right ventricular failure with carvedilol for a couple of weeks. With one single dose, we did not up-titrate. And here is the interesting story. Normal right ventricle, failing right ventricle, fibrotic, and after treatment, the fibrosis was gone. If you look at the capillarization, the decrease in the capillary number in the failing right ventricle was coming back, was reversible under the treatment of carvedilol. PGC1 alpha expression in the right ventricle responded to carvedilol treatment, which means that likely many of the downstream effects depending on the transcription factor could have been repaired as well. And when we look here with immunohistochemistry to the degree of autophagy as a marker of cell derangement in the failing right ventricle, you can see all of the red markers here are expression of that autophagy marker LC3B. There is much more of that red signal after 2 weeks of treatment with carvedilol. So the capillaries came back. That asked us the question, well, how can that be? How can the drug bring capillaries back? So we looked at the gene expression pattern after treatment with carvedilol in just normal rats, and lo and behold, you can see that there is the gene expression upregulated of a number of angiogenic factors, angiopoietin-1, apelin, vascular endothelial growth factor, and transcription factors like HIF1 alpha and HIF2 alpha. So very likely this drug is pro-angiogenic in the setting of failure. We took that to the clinic and we treated 6 patients with established, long-time established severe pulmonary hypertension and added on carvedilol to the treatment, which was either prostacyclin infusion or endothelin receptor blocker. And in all of these patients, after 6 months of treatment, there was an increase in the right ventricular ejection fraction. This was more than 2 years ago. All of these patients are still on the drug. I know that locally here, you have been doing a study looking at the effect of beta blockade on cytokine concentration, but the drug that was used was bisoprolol. And that gets me to the heart of the matter, so to speak, which is that carvedilol is unique, is single among all of the beta receptor blockers that you can think of, starting with propranolol, bisoprolol, and so forth. And if you need to be convinced, go back and read that paper by Bob Lefkowitz. It's a couple of years ago now. Leave this on. The first author is Whistler. And you get the molecular rationale for why carvedilol is different. It is antioxidant, it's anti-apoptotic, it is anti-inflammatory, and it is also working on the mitochondrial level. This is from a group at Cleveland. They showed that the phosphorylation problem that you see in regards to endothelial nitric oxide synthesis in the pulmonary arteries is reversed by carvedilol, another reason why this might be a good drug. So, if I want to summarize, in the failure situation, we have insufficient hypertrophy and no growth. At some point in time, there is no more growth. There is a constellation of disruption of coordinated hypertrophy and angiogenesis. There's energy problem, production and consumption problems, and as a consequence, you get to contractility impairment in spite of high adrenergic overdrive. What we don't know is what the genetic components are, and this is high time we have the tools to go and look for those now. So, I want to summarize. Successful adaptation to chronic stress prevents the development or minimizes the cellular and molecular abnormalities that are characterizing the failing myocardium. And successful treatment, in my mind, will reverse the capillary rarefaction. The blood supply, the energy supply on the tissue level is critical, and also the fibrosis by reducing the tissue stress. So the failure is to be understood on a cellular and metabolic level. I hadn't time to go into the mitochondrial dynamics of that. And to continue the summary, both genetic and epigenetic factors determine successful adaptation. RV failure can be defined as a loss of function and on the tissue and cellular level, and the hallmarks of tissue level on the tissue level are fibrosis, capillary rarefaction, apoptosis, autophagy. Hallmarks on the molecular level are cell stress signals, no growth, and energy metabolism problem. Thank you very much for your attention.